Dr. Silva, and I'm here to tell you about Amoxapine, Asendin, a tricyclic agent, sometimes classified as a tetracyclic agent, that is an SNRI. It's a serotonin norepinephrine reuptake inhibitor, like the other tricyclic agents. And it is more noradrenergic than serotonergic, so it blocks the reuptake of norepinephrine more so than serotonin. But it is still not a medication that you probably would want to combine with a monoamine oxidase inhibitor. You still have to worry about serotonin syndrome, combining it with other medications that are also highly serotonergic. But Amoxapine is a little different than the other agents because it actually was released in the United States in 1980, which is about 10 to 20 years after the other agents in that class. And so even though the tricyclics are considered a first-generation antidepressants, this medication was a latecomer, and I have the dinosaur joke as kind of a running theme in my recent talks about tricyclic agents, but really this one wasn't as long ago as the late 50s and 1960s, which is when the other medications were developed and released. But it also has the distinction of being a serotonin 2A receptor antagonist. So it also antagonizes or blocks the serotonin 2A receptor subtype. And the significance of that is that it may have additional antidepressant action. I'll talk about that in a second. But Amoxapine is actually the active metabolite of the conventional antipsychotic loxapine. So loxapine is a dopamine D2 receptor antagonist. It blocks the dopamine type 2 receptors, and that has been proven to diminish psychosis. And specifically, it blocks hallucinations, and it helps to diminish paranoia and other delusions, and also has mood stabilizing properties, so it curbs mania, and especially psychotic mania. And so here we have a medication which has antidepressant actions, but also has antipsychotic actions because its active metabolites, 7-hydroxy and 8-hydroxy active metabolites, are 2A receptor antagonists and also D2 receptor antagonists. So when you take Amoxapine, you're taking a medication that metabolizes into other medications, all of which have this property of not only blocking the reuptake of serotonin and norepinephrine, but also antagonizing the serotonin receptor 2A subtype, as well as the D2 receptor subtype. And so you get antipsychotic and additional anxiolytic and antidepressant actions. And in fact, we talk about how the tricyclic agents might be better antidepressants than the more modern agents, the selective serotonin reuptake inhibitors, and possibly even the modern SNRIs. There's evidence to show that they may be more useful for treatment-resistant depression. And this makes sense, especially in the case of Amoxapine. When you think about the fact that Amoxapine is metabolized into active metabolites that block specifically 2A in terms of the serotonin receptor, that is very similar to the atypical antipsychotic agents, the third generation agents like Abilify and Vraylar, that are used as augmentation strategies for antidepressants. So a lot of times when we're getting a partial response to an antidepressant, we will add Abilify, for example, which again is a serotonin 2A antagonist, as well as a partial dopamine agonist. And that improves depression and it decreases anxiety in those patients. This isn't exactly the same because we're talking about a 2A blockade, but we're not talking about partial dopamine agonist, but we're talking about a dopamine 2 antagonist. But still, it does have that extra 2A antagonist boosting capacity. And so it makes sense to me that this would be a superior antidepressant to maybe the SSRIs, the straight-on SSRIs. Plus, it has antipsychotic properties because it blocks the D2 receptor. One of the FDA indications is for quote-unquote endogenous and psychotic depressions. It makes sense that it would be good for depression that has psychosis as a component. And I also would think of it in terms of off-label, but in terms of bipolar depression. It's also FDA approved for the treatment of quote-unquote neurotic or reactive depressive disorder. It's funny about these older agents because they don't necessarily correlate with the DSM. There is no diagnosis that is a so-called, quote, neurotic or reactive depressive disorder. That's not something that we diagnose. But when Amoxapine was being studied and approved by the FDA, it was approved for that. And so if the clinician determines that whatever the diagnosis is, according to the modern nosology, meets criteria for that, then it's something to consider. And also, quote, depression accompanied by anxiety or agitation, close quotes. Agitation is sort of a nonspecific term. Again, if it were psychotic agitation, especially. But these medications are used to treat anxiety and insomnia, off-label insomnia because they're very sedating, mostly due to their antihistaminergic effects. They're also used off-label to treat chronic pain, especially neuropathic pain, and they prevent migraine headaches, etc. They're even used off-label to treat smoking cessation and cocaine addiction, although probably the ones that you would want to experiment with in addressing those conditions would be the most noradrenergic agents, i.e. nortriptyline and diazepamine, as opposed to this medication, which is somewhere between those medications and imipramine and clomipramine, which are on the serotonergic end of the spectrum. Again, Amoxapine has greater norepinephrine reuptake blockade activity than serotonin, but it does have both. Side effects. Well, first of all, the nonspecifics. Nausea. Any medication can cause nausea. Headaches. Diarrhea. Dizziness. Fatigue. Those are nonspecific side effects. A big one, though, is sedation. And we think this is mediated by these medications' antihistaminergic effects. So they're essentially antihistamines. And so they block the H1 type of histamine receptor, the type that's involved in seasonal allergies, not the type that's involved in your stomach acid. We're talking about blocking the H1 receptors. They are found in the central nervous system, and they result in sedation, which can be very significant. Mirtazapine is a tetracyclic, a little bit more modern antidepressant that's used a lot, and it too creates sedation through its antihistamine effect. So you want to dose these medications at bedtime. You want to try to use them as sleep agents as well as antidepressants. And if you do have to dose them throughout the day, you want the larger dose to be at bedtime. Weight gain is another real problem with these agents. They increase the appetite. They don't change the metabolism. They increase the appetite, especially for carbohydrates. For some reason, you're not going to crave broccoli, but the pastas and the sugary sweet foods, you're really going to want those more, and you're going to gain weight from that, and it could cause metabolic syndrome, type 2 diabetes, hypercholesterolemia, elevated cholesterol, as well as a bad ratio of the quote-unquote good cholesterol to the bad cholesterol, dyslipidemia. You really do have to weigh patients at baseline and monitor them very carefully. That's a huge drawback and a deal breaker for a lot of patients. They also, all of them, to some extent or another, block muscarinic acetylcholine receptors. So they're anticholinergic, and you get all of the side effects that go with that, from dry mouth to constipation, to urinary retention, to blurred vision because it impairs accommodation. So you get blurred near vision. The pupils can't accommodate. All of these medications can cause sexual dysfunction, mostly anorgasmia and a lowered libido because of the serotonergic actions, but you can also get erectile dysfunction. That could be a consequence of a low libido, but it could also be a direct effect of norepinephrine, which inhibits the parasympathetic nervous system and interferes with the erection. In a lot of men, particularly men that are middle-aged, they might have other risk factors like cardiovascular disease, chronic hypertension, etc. Orthostasis, orthostatic hypotension, is a loss of blood pressure, a drop in blood pressure in the cranium upon standing. Ortho means upright, erect, stasis, to stand. And so when you get up, especially if you've been lying down or even sitting down, and you come to a standing position, the blood pools due to gravity, and your vasculature is supposed to compensate by constricting to maintain pressure, but you get interference with that system with these medications, and that can lead to dizziness and even fainting and falling. We do see severe hypotension in overdose. You want to get a baseline EKG in your patients that are older than 50, because these agents can also cause QTC prolongation. QTC stands for the corrected QT interval, and that refers to the electrocardiogram, the QRST complex, which measures in milliseconds the length of a heartbeat. So in patients who already have varying degrees of heart block, you want to avoid using tricyclic agents, or in patients that already have arrhythmias, because prolongation of the QTC could lead to fatal arrhythmia, a torsade de points, which looks like this and looks like this. Again, these medications are fatal in overdose. You see seizures, arrhythmias, fatal arrhythmias, coma, and death. Definitely not a good choice for patients that are chronically suicidal or the patients who are prone to overdose. Other side effects include sweating, increases sweating because you have the increased norepinephrine, and so upon exertion. But also you could, in theory, have hot flashes as well, temperature dysregulation. That's due to increased serotonin. I have another video, it's an instant replay on sweating, on drug-induced sweating, so you can check that out for more information. Heartburn has been reported, a weird taste in the mouth, that can happen. These are not as common. Akathisia, which is a motor restlessness, a fidgetiness, a need to move and feeling very uncomfortable if you can't move. In the extreme, it takes the form of pacing, but probably more commonly you would see fidgeting, squirming, inability to stay seated, maybe a bouncing knee or a tapping toe. That's called akathisia, and it's due to increased serotonin, which is antagonizing dopamine in certain regions of the brain. You can also see rarely the induction of mania in those individuals who are susceptible to it. So patients with bipolar spectrum illness, you're not going to see mania in patients that aren't prone to manic episodes. Even in overdose, you're not going to see mania unless you have a person who's bipolar. And similarly, patients that are vulnerable to psychosis would be at increased risk theoretically, but this is rare. Controversial side effect would be suicidal ideations. Any antidepressant, in theory, especially in young, impulsive people, could, in theory, increase suicidal ideations and even behaviors. This is controversial. It's not really been proven. I am on the side of there's really very little proof of that, and I certainly don't worry about it in really any of my patients. Definitely not in patients that are older. But I warn all patients about it. I ask all patients about suicidality, whether they've had problems with depression or not. And I do caution them that if they start to have thoughts, weird thoughts, to let me know. In a young, impulsive patient, you really do have to be careful about that. There is going to be a greater tendency to have akathisia with this medication because of the dopamine blockade, the D2 blockade of one of its active metabolites. And this medication is also much more likely to cause drug-induced Parkinsonism, just the straightforward bradykinesia and tremors and rigidity that you would see with the conventional antipsychotic agents. You're going to see less of it because we're talking about active metabolites that have a half-life of only 24 hours, but it's still something to consider, particularly at higher doses. And also, in theory, at least in theory, you could develop tardive dyskinesia with this medication. Tardive dyskinesia is, as the name implies, tardive. It comes after usually at least a few months, if not many years, of therapy, of blocking the dopamine receptors for a long time. You could see this permanent movement disorder that I won't go into a whole lot of detail here. It's a theoretical risk, but it is something that you would want to warn patients about when you're obtaining informed consent. Because again, at high doses over many years, when you've got blockade of those dopamine receptors, you could unmask this, what could be a permanent movement disorder. You really see it more with the high potency agents like Haldol and Risperdal. If you give them for a long time, you rarely, if ever, see it with the low potency agents like Seroquel, but I would definitely be very careful about tapering amoxapine, lowering the dosage slowly over a period of weeks to months if you've administered it for longer than just a few days. Other drug-drug interactions are very similar to other tricyclic agents that might prolong the QTC interval, so you want to be careful about combining it with certain antiarrhythmic agents and certain antibiotics. As with the other tricyclic agents, you want to be careful about combining it with other anticholinergic medications because you could get toxicity that could be fatal in overdose. You can get hyperthermia or a paralytic ileus that might lead to perforation. And then because amoxapine is also metabolized by the cytochrome P450 enzyme system in the liver, specifically 2D6, you want to be careful about combining it with other medications that inhibit that enzyme, such as Paxil, Prozac, Wellbutrin, Cymbalta, because those medications would increase the drug levels of amoxapine, and that could lead to increased toxicity and increased risk of death. There's also a concern about lowering the seizure threshold, and so care has to be taken combining it with tramadol, the opiate analgesic, which is also an SNRI, so in theory, serotonin syndrome, though again, amoxapine is not particularly serotonergic. The other thing that's notable about amoxapine is that it appears to have a faster onset of action than the other agents, as quick as a week or two, whereas most other medications take 2 or more weeks before you really see significant improvement in depression or anxiety. Again, a special niche for amoxapine is psychotic depression. And this is assuming that the patient doesn't have an underlying primary psychotic disorder like schizophrenia. But even in those patients, if they have a particularly recalcitrant psychosis that's not responding very well to the conventional antipsychotics, you might think about amoxapine if you needed a tricyclic agent in treating depression, which is very common in those patients. If you are interested in getting an overview of all of the tricyclic agents, please check out my video on all of those agents. I talk about amoxapine as well as all of the other major agents in that video. Thanks for listening.